All right, this looks really good. I saw some really good stuff walking around. Let's recap just a little bit, just make sure that everybody got some of the key take-homes. I think y'all did some great work on this. I'll go ahead and leave it here just so we can keep cycling back to it. But what were some of the manpower issues you identified? And feel free to regurgitate what I gave y'all earlier. Or come up with something new. Nurse didn't follow policy. Okay, so we got a human factor. So the only conclusions we can draw from that is that the nurse did not follow policy. We do not know why. The tricky thing in this is do not imply motive, right? So what could have happened is it could have been either the nurse didn't know about the policy is not part of group norms, it could be that the policy is difficult to find, or it could be that this nurse didn't want to follow the policy. It could be any of those things. So it could be malevolent, it could be not, and that's whenever we go down the progression of culpability. Okay, what other people factors were involved? What other manpower factors? What about the physician? What did the physician not do or do? Signed off on an inappropriate drug order. We can say that because this all kinds of violates Joint Commission standards, right? Okay. All right, good. So the physician. Any other people involved? Pharmacist. What should the pharmacist have done or not done? Yeah. Yeah. Hopefully, if from the patient safety stuff, if y'all take nothing else from these, I mean, the big thing that I hope you take from it that stays with you is that you are a cog in this machine. And you can stop the line anytime you want to. And that's okay. And you should, if you feel it's the right thing to do. If you're wrong, no harm, no foul. You go, oh, my bad, sorry, I guess I was being a little over-conservative. But if you're right, you could save somebody's life. Okay. Anything else on the people? Any other thoughts on people? The patient. How could the patient, or we'll even make it broader, we'll say patient or patient's family, right? So patient or patient family, what could they have done or not done? Yeah. Did the patient, we don't know that, right? We don't know if no, it's great. Did the patient understand the pain scale? Did the patient know what type of drug they were getting? Did they understand the drug they were getting? Also, I'm sure at least some of you have had this experience where somebody tries to give a drug to your family member while they're in the hospital or something like that, and you say, no. He or she doesn't handle that well, right? So how can we impact that? Is that random, or is there something we can actively do in our healthcare organizations to make that happen? Patient counseling education. Also, most importantly, this is why patients and patient families should be involved in their care. Long gone are the days of patriarchal medicine, or at least we hope they are. So yeah, so we could have the patient involved. I'm so glad y'all caught that. Okay, let's go to, do we go to methods next? Let's go to methods. What about methods? What did y'all identify as problems with methods? Pharmacy approved the order. What's the policy, right? What is pharmacy's policy for addressing an inappropriate order? Do they practice Nike Pharmacy and they just change it under protocol? Do they have to call the physician or the other prescriber? Like, what's the deal? Like, we have a policy on pain management. Do we have a policy addressing inappropriate orders, how we handle inappropriate orders or potentially dangerous orders? That's a good one. What else under methods? The order set. Yeah, the order set is a tool, right? So you could put the order set, so I was telling a few groups, and just so I've said it to everybody, this isn't rigid. I'm going to get to it. This isn't rigid. Like, you don't have to use these 5 categories. You can use 5 categories that make sense. I've historically done these 5 categories so that we don't miss anything. But the range orders could go under methods. So how do we deal with those range orders, right? Or range orders are acceptable or whatever. You could theoretically put them, where else could we put it? I'll ask you all rather than telling you. Where else did you put range orders? Measurements. Yeah, measurements. Yeah, measurements is a great spot for that because basically you're looking at, how do we measure pain and how do we measure the dosing of our drugs? There's a wide, when you have a range, measuring a range, is that really an accurate measurement anymore or an accurate number anymore? Okay. How about machines? What did y'all identify on machines? Yeah, how are we monitoring the patient? That's actually a really good one. So what are we don't have that in our extra information here, but how do we, if they found the patient non-responsive hours later, how long was the patient like that? We have no idea. And so why didn't the alarms go off? And if the alarms went off, why didn't they respond to them? Right? So if they were monitoring O2 sats, that should have tanked. If they were monitoring heart rate or ECG, that should have tanked, right? And we should have caught it right then, and that's when the code should have happened. We shouldn't have just found the patient unresponsive. That's a wonderful catch. What else under machine? The order set. Yeah, the electronic order set. We create bias. I've had the privilege, I don't know how many of y'all have, but I've had the privilege of living in both worlds. I experienced what life was like before electronic health records, and I experienced what life has been like after them. And I can tell you, it's really funny. We got rid of a whole lot of problems, and we created a whole lot of new ones. I think it was for the better, but the new problems are we create bias in our order sets. When we pre-select things, when we create selection buttons, when we do those types of things, we motivate decisions. Sometimes, and I told them back there, sometimes we use this for the power of good, right? We were purposeful about it. I put 0.125 and 0.25 as radio buttons, selection buttons for digoxin, so that some ding-dong doesn't put in 10 milligrams, right? Keeps me from having to make a phone call, all right? But the danger is, what if I pre-select 0.125? Patient's on 0.25. Somebody that's being careless, we just change the dose without meaning to, right? And so there are machine issues here. So by having this order pre-selected in the order set, we have biased our prescribers to roll with that order. This must be what the hospital wants me to prescribe, so I'll prescribe it. Okay. Let's see. Materials. We had some good discussion on materials going around the room. What did we identify as far as materials? Exactly. Pain management alternatives. Modalities. I asked the question over here. I'll ask it to the rest of the room. If you have a pain of 2, what are you going to take? If anything. Nothing? Yeah. Yeah. Tylenol? Okay. Ibuprofen? Okay. Vodka? Is that a water bottle or no? I got to make management interesting somehow. Golly, that's awesome. Yeah, so you're going to take something mild if you take anything at all. Where were the non-opioid pain alternatives? Who the heck takes 1 to 3 milligrams for a pain scale of 2, right? And so I mean, it might not be unreasonable in a certain patient population, maybe. Okay, why do you think hydromorphone was the drug of choice here? What would motivate someone to have that as the order set primary? When is it, let me re-ask the question, when is it appropriate to use hydromorphone? Sure, somebody that needs more acute pain management. Okay, who else? They don't respond to non-opioids. Yeah, so it's severe pain, right? So they have a higher pain tolerance, pain threshold. They can take a big hit. What else? Who else? Sure.